Okay, everybody. So welcome to this live stream. Usually I tell people that I do these maybe once every other weekend, maybe once every 3 weekends, maybe 20 minutes at a time. I try to talk about different topics of spine surgery, my background, board certified spine surgeon, and happy 2 days after match day for those that know what match day is. That's actually, I don't know. It's always like that certain Friday in March. I'm sure it's like the 3rd or 2nd, something like that. And that's when all the medical students in America find out kind of what type of doctor they're going to become. They find out where they're going to be going doing their residency. But that's not the point of today's thing. The point of today's thing is talk about back pain, talk about spinal stenosis, and let's focus on some Q&As, some definitions, and let's kind of just get right to it. So in terms of spinal stenosis, that can be in the neck, the cervical spine. It can be in the lower back, the lumbar spine. It can be in the thoracic spine. It's just very less common to have thoracic spine issues because of the rib cage, because of the anatomy. Usually it's the lumbar spine and the neck. I'm going to use this lumbar spine as an example, and just as a very brief anatomy reminder for everybody. The spine goes bone, disc, all the way down, and behind, this is the front, so it's like the belly. Here's the back part. But behind the bones is when you have these nerves running down the thecal sac. It's like a garden hose, a tube with a bunch of spaghetti noodles running down it, and you have fluid in there. That's the spinal fluid. So that's the thecal sac. It actually have it kind of starting at your neck, but it's the spinal cord. The spinal cord runs all the way down through the neck, through the thoracic spine, and then at usually T12 or L1, it becomes that sac with a bunch of nerves running down. So most people don't know, nor should they know, that your spinal cord actually stops kind of here at the rib cage in the back, and then it's a bunch of sac with nerves running down. So not to split hairs, but this is actually not the spinal cord. It's the thecal sac, a bunch of nerves running down. And then at every level, neck, thoracic spine, lumbar spine, we have these holes, these tunnels, these foramen. So here's a disc replacement model, but there's nothing in this one to show you. So where this nerve tunnel is going through right here, this nerve tunnel, that's the that's the foramen, and that's where the nerves run out, and they go to different parts of the body. So that's the background anatomy. Now let me just give you the definition of what spinal stenosis is, and then let's get some Q&A. Spinal stenosis is, again, neck, mid-back, lower back. When you get thickening, tightening of this tunnel here that squeezes all the nerves. So this tunnel here, here's a smaller model, again, to orient you. This tunnel here squeezes those nerves, causing spinal stenosis. There's kind of 3 different degrees. There's mild, moderate, severe. It's more of an MRI or radiographic definition. Mild could be very painful. Severe could not be painful. So it's more of a radiographic definition. Obviously, severe is worse. You don't want to have severe compared to mild. But just because you have severe doesn't mean you're even symptomatic. We'll kind of get to that during our little journey here today. Again, appreciate the likes, shares, comments. That kind of helps promote this to other people. Please don't send any gifts. Keep your money for other people trying to make money on social media. That's not the goal of this. This is just purely educational. Go ahead and ask questions. I can't give advice, and let's get going. First question I see a lot is, who am I? Good question. I'm a spine surgeon here in my hometown, Dallas, Texas. I'm in a 6-person spine surgery group. What is spondylolisthesis? Good question from Hannah. Hannah, spondylolisthesis is when you can have, there's 6 types, but in general, 2 types are, you get severe arthritic, these joints in the back, arthritis, and normally if your joints kind of lock in place, they don't, they move, but they kind of lock in place, right? Like I can't dislocate my wrist, right? You can move it, but I can't dislocate it. You get so much arthritis that almost like the bones kind of jump over each other in a way, like they don't lock, they jump over each other. That wears out the disc space at a faster rate. That causes back pain. And then it's a little hard to show on this model here, but you can imagine how it's like stretching this nerve right here. Spondylolisthesis, degenerative type. That's one type. The other common type, but less common, is when you get a pars fracture. It's usually down here at either L4 or L5. This pars fracture down here, it's usually 4 or 5. Bones of fracture is from hyperextension. Could be from trauma. Hyperextension. And that crack also causes the instability. So that's what spondylolisthesis is. Go to my YouTube. I have so many good videos on it. And I'll try to get these questions. Again, appreciate the likes and follows. And I can jump on it for about 20 minutes. What is something you'd never do while you're young? Probably in terms of like the spine. I'm trying to think like something crazy that really hurts your spine. I don't know. I'm not saying like don't motorcycle or skydive or jet ski, because those are all fun things to do. Maybe don't make your profession riding horses. I say that with someone in my family that's made it their profession, and her husband, my brother-in-law, just because like that's pounding your back all the time. How about that? Do I take insurance? Yes, but this is not an ad for me. You can go to my website. I have info. I don't take Medicaid. We don't take most HMOs. Thoughts on Botox for ON? What's ON? Occipital neuralgia. A little outside my wheelhouse, but I'm in typical favor of that. Do they remove L4, L5? I might miss your other question. Sorry, I got about 1,000 people in the chat. Questions are coming in fast. I apologize. Please, I have 2 protrusions in the thoracic spine. Are they symptomatic on my heart? No, they would not be symptomatic on your heart. I had a karma. Ooh, that's an interesting question. I had a karma fixation in 2022. I'm in bad shape. It's moved to my sacrum. From Angela. I've done the karma fixation. I might do it about 2 times a year. Pretty much what that is, it's a fusion in the spine, but instead of using these pedicle screws like we have here, it's like a zip tie. I almost exclusively reserve that for pretty older people, usually females, with osteoporosis. Osteoporosis, that like someone that's really old that needs a fusion, but like you really don't want to do a big fusion. The most recent one was actually on a 93-year-old, believe it or not. And if you're like, oh my God, you did surgery on a 93-year-old, well, yeah. Like if someone's 93 and they need a surgery, then what do we do? Just tell them to live with their pain. But she had such a bad slip and it was unstable, but I'm not too excited to have to go put pedicle screws in someone. So that's the time I use the Karma Fusion. And she's pretty acutely post-op, maybe 3 months post-op. She's doing fantastic. But she's not your typical 93-year-old, she's more of like a 82-year-old, if I'm allowed to say that. But yeah, that's the karma thing. So now you're in bad shape. Well, hard to say your case. The karma, again, I just save it for really osteoporotic bone where people kind of need a fusion, but I really don't want to do a fusion on them. How about that? Do you know what snake eyes are inside the cord after spinal cord? Interesting. Spinal cord injury. Yeah. So think of it this way. It's a radiographic finding of something called myelomalacia. It's something that you could get from a trauma, but you can also get it from a chronic degenerative state. It's called myelomalacia, and it's a fancy word for, if you looked on a clear MRI report, it's death of spinal cord cells. It's not good. It's irreversible. Pretty much on the MRI, hydrogen on a certain signal intensities show up as white. So you have white in your spinal fluid, good. You have white in your fat, good. You have white in blood cells, good. But you shouldn't have white in the spinal cord itself. Except when cells die, they turn into water, for lack of better words. And that's what myelomalacia is. It's like a bruising. And so spinal cord injury, it's a traumatic thing. You can be able on the left and the right side. It could be the snake eyes thing. Is another way to think about it. Your video about facet arthritis and non-invasive surgical options, can you elaborate? Sure. So facet arthritis is painful. That's when these joints are rubbing. In terms of what to do about it non-surgically, there's not like some way just to go in there and just shave down the arthritis, which would be a surgical way. And we're talking about the non-surgical ways. So the non-surgical ways as well, if you have arthritis, how do you make it go away? Think of it somewhat similar to arthritis in the knee or arthritis in the hands. There's not just some magic way just because it's spine surgery and all fancy to make that arthritis go away. Things we recommend is activity modification, such as if you're a smoker, stop that. That hurts arthritis. If you have poorly controlled diabetes, control it. That's a modifiable risk factor. Control your diabetes. That helps with arthritis. Then there's certain rheumatoid medications you could try if you have an autoimmune. But the other things that you could work on is certain guided formal physical therapy. I'm okay with some chiropractic therapy, even though I'm a spine surgeon. They're not all. Most of them actually aren't bad at all. So I'm okay with most chiropractic things. I'm not okay with neck popping or Y straps, things like that. But there's definitely a role for chiropractic intervention. A spine surgeon that tells you otherwise might be a little too biased on that, but chiropractic doctors are good. There's some bad actors, but I'm sure there's some bad actors in spine also. Other things that would help are steroid injections, epidural steroids that calm down the inflammation. It wouldn't be epidural, so it'd be facet injections, and the facet joints are helpful. RFAs are good. I see Dora Athena asked about the intracet procedure. That wouldn't be for the facet injections. That's more so when they put the needle in this vertebral body here. So the needle kind of goes from the back in the vertebral body. That's a good role for back pain. PRP injections, stem cells, those are fine also. It's just a little not great peer-reviewed studies on high-impact journals and spine journals that we validate to show those are extremely helpful in reversing stuff. I see one from Apple user, Spine Fellowship this year, wondering what I should ask in starting private practice. Well, there's a whole lot of stuff that you can do there. I guess, first of all, congrats. I would recommend private practice over academics. I always thought I want to do academics, but I'm on many recorded lines here, so I don't know how much I want to say completely. But in general, academics, you're working in general, not always true. You're working a lot harder for a lot less money, and you're not doing it for the money. But I also like seeing my family. And one thing I found out pretty quickly from academics is, on surgery days in private practice, I'm getting at the hospital 6 a.m., right? So that's 2 days a week, maybe 3 days a week. Well, great. But if you have little kids, if you have a family, if you have a wife, well, that sucks. You're not at home helping out your family 2 or 3 days in the morning. It kind of stinks. Well, private practice, the other days are clinic days. So those days those days you can take your kid to school. One of the bummers about academics I came to find out is, you pretty much get in the hospital every day at 7 a.m. for like grand rounds, rounding, journal club. There's always something. That's a lot of unpaid work. And again, it's not about the money, but I don't know, if I'm going to be away from my family, at least I'm trying to build a good future for them as opposed to doing a lot of free labor. So that's just one way to kind of think about academics versus private practice pretty quickly. It's just family life. Another thing that's interesting that you should kind of look into is how many other spine surgeons in the group, if it's multi-specialty or just spine only. I'm biased. I think having a spine only is pretty good. You have to work a little harder to get your referrals, but everyone's on the same playing field, in terms of your overhead, in terms of collections, things like that. Like, you're all spine surgeons, so it's all apples to apples. Feel free to direct message me. I'm happy to tell you more of my thoughts. The person who's in fellowship now, I'd love to share more, but probably 99% of people listening in are going to be super bored on some of these topics. From Toby, any research opportunities for you as a med student? Toby, you can direct message me. There's one paper that one of my buddies was looking for someone on. This is like 2 months ago. Maybe he's found someone since then, but I have a research team already kind of pumping out stuff right now, and I don't think they're looking for anyone right now to add it to it. I apologize. Chiari malformation. I don't treat Chiari malformations. I apologize. I have hand atrophy and a pinky that's numb from Bree. Bree, that could be from the cervical spine. The C7 root could have spinal stenosis and pinch there. So spinal stenosis in the middle part could lead to that, but also the nerve tunnel coming out definitely could lead to a weakness in that area. From Victoria, she said my T-score is a negative 3.6 and basically have no relief. So if your T-score, that's osteoporosis, that's pretty bad. Anything under 2.5, so it's like a weird number in the system. It's almost like golf. Well, I guess it's the opposite of golf. The more negative, the worse. But under 2.5 is osteoporosis. So like negative 1.5 is osteopenia. Negative 3.5 is very bad. You definitely want to be on bone strengthening medications, even if you're not having spine surgery, because you could fall, break your wrist, fall, break your hip. That's a big deal. Interesting question coming in. Do you think you could do anything with my quadriplegic son with Klippel syndrome? No clue. Honestly, who knows? Not really sure. It's something where if there's a spinal cord injury, usually those things have a short window, either 12 hours to 2 days to get to a spinal cord injury. If there's Klippel, that's kind of something you're born with. That's a chronic condition. So, again, I don't know the whole story just hearing it, but you're talking about something that you're born with, like an autofusion of the neck, and then quadriplegia. I don't know the timeline of that, but that's just for those at home interested in those two terminologies. Usually if you have a spinal cord injury, the golden window to get to that is somewhere between maybe 12 hours to 2 days. 2 days may be on the very longer end. So I'm not advocating for that as well, but not trying to put anyone in the hole either. From Andy, I have osteoarthritis at L5S1 as well as annular tears. So I need a fusion of that area. No, you don't need a fusion of that area. How do I know? I don't, but having just osteoarthritis isn't an indication for a fusion. It's pinched nerves, it's revision stenosis, it's instability are some of the indications. Someone's asking, what is Cauda-Equina syndrome? Well, there's acute and there's chronic. Acute is where you get, usually it's compression of this down part here. It's the Cauda-Equina, the tail, and that could lead to insufficiency of all those nerves. That is a surgical emergency in most settings. Degenerative asymmetric disc at young age, is that common? Not terribly uncommon, but the things I would recommend is just kind of managing those symptoms. If they're starting to be degenerative, then just pay extra attention to them and don't do things that you think could make them worse. From KM, what would spinal stenosis and nerve crowding at 3-4 cause shoulder and arm weakness? It would not. No, and at L3, L4, that's the lumbar spine. That typically correlates to knee extension, like some quadricep muscles. It could be some foot drop, the ankle coming up, not as common. It could also be the thigh pulling up to the sky, but usually it's kind of that extension out of your legs. things in the lumbar spine would not correlate to things in the neck. Again, appreciate the likes coming in. Appreciate the comments. I do have to do one thing to my phone here, so it's going to give you a paused feed. I just have to check a text. 1 second here. Okay, so sorry, just reading a couple text messages. Okay, let's get some more questions here. Is another fusion all that's left? I must have missed those other questions coming in. Sorry, they're coming in pretty quick here. How does lordosis occur? You're born with lordosis. Lordosis is curvature. You want curvature in the spine. So lordosis is the spine, either the neck or the back. You want curvature. You want lordosis back because you want your gaze to be in the horizon. When you have disc collapse at multiple levels, so say you get degenerative disc disease in the lumbar spine, your spine starts to lean forward. So what do? You start to flex your hips back, bend the knees, so I'm trying to pull your back. Well, that's what gives you the back pain here. So it's kind of a cyclical thing about the degenerative disc disease that leads to all that. What systems do you use? Medtronic, Stryker, other. For systems for navigation, I use Medtronic's O-arm, and I also use Augmetics, augmented reality. And then for hardware, I use everybody. If I had to pick one brand more than the other, maybe Globus, but that's just more so because I think the reps are fantastic, and they have fantastic stuff in terms of products, but I have zero financial ties to Globus. But I use Globus NuVasive now, so that's also probably why I like NuVasive a lot. I like Globus a lot, and they combine. So kind of get the best of both worlds there. Does thoracic radiculopathy require surgery? Sometimes. Thoracic radiculopathy is pretty rare, though. Hemivertebrae, man, we got some crazy conditions going on today, not just this normal wear and tear stuff. Sorry, I missed your question. It's gone now, but ask again. I'll see that. Does red light therapy work for disc degeneration? I don't think it hurts. I haven't really done extensive research on red light therapy. I usually say, look, if it's not breaking the bank and if it's helping, then keep doing it. But, a lot of that stuff's little voodoo medicine, but if it helps, it helps. How about that? Hey, doctor, what causes, oh man, these questions are coming in hot and heavy. What causes pain in the back in the right calf? Larry, not sure. The calf is usually a L5 or an S1 nerve, so it could be that. What about Elon's neck? I don't, understand 100%. I haven't really actually looked into it. I think he had a disc replacement and then went on to get either another disc replacement or fusion. Legitimately, I haven't looked into it much. But I remember when that first happened, one, I was annoyed that he was negatively commenting on spine surgery. And two, again, I know zero about the case, right? For real. I really have not even done a Google search. But I definitely, in our group chat, we talked about it. If you have a billionaire and the most high powerful person coming in, you do things differently, and that's not good. And I tell patients all the time that are doctors and physicians, I'm a doctor, if I'm treating a doctor, whether I want to or not, we just treat them differently. And maybe we do something that we wouldn't normally do. Say they're man, I really don't want a fusion. I only want a disc replacement. And I'm fine. Well, this is a doctor. He's asking, I want to make sure this doctor gets what he wants. And so then I do a disc replacement. Same thing with a billionaire or the world's richest man ever. He was I only want this procedure. And you're well, it's kind of a rough contraindication, but it's probably okay. And then you go ahead and do it anyway. And then they have a bad outcome. It's not that. It's, there's so many other little factors. But in general, when you do everything by the books, FDA or IDE studies is probably the better way to say it, the traditional way to do it, that's when you have the best outcomes. So again, I do not know about Elon's case. I really don't. But I can, when I first heard that, I'm well, look, I bet whoever I don't even know that I'm not trying to, the spine surgeon could be my boss and I'd get in trouble for saying that. But I could just see sometimes when you treat doctors or high profile people, you might do things just a tad differently, trying to do them a favor. And it's not, same thing now. I got one of my good friends, he's probably, I say good friends. He wasn't my friend until he was a patient of mine, but he's texting me a lot right now, even as we speak, because I operated him 3 years ago and then maybe 2 years ago. He was doing good, but now he's had this one issue that's keeps being an issue. And, I feel like just trying to diagnose and texting him isn't the way to do it, right? I need to see him. And sometimes you just kind of cut corners by not meaning to, because you treat someone a little differently. And that's just something that's just in the back of my mind. Even talking with him about his case, he's well, hey, how about we just go do surgery? I'm not going to say the date for HIPAA reasons, but pretty soon. And I'm you know what? I really just need to get him in the office, see him again, because it's one of these things where you just do things a tad differently, where you have a little issues. And that's sometimes when you treat high profile people, the world's richest man, Elon Musk, things like that. So a little bit of a tangent there, but I think it's an interesting way to think about your treatment. You just want everything done basic, by the books, and that's a good way to do it. Good question from Nicholas. Could you speak about the recovery time for a 2-level low back pain fusion surgery? Sure, Nicholas. Well, a lot of ways to do it, either going through the front, side, or back. But let's just say I'm doing a 2-level A-lift with posterior spinal instrumentation. So that's 2 levels of spinal fusion. I'd be using a very high-tech cage, kind of like this one here, where the cage goes in, these blades or screws go into these disc spaces. And then on the back, I think my pedicle, oh, actually, here's a pedicle screw model. I make a little slit. So if here's the spine, and on the back of the spine, like if this is, this is your fat, muscles, here's your skin. I make a slit incision, probably the size of this part of the pin here, like that part that clips onto your jacket, a slit that big. And then I put on my navigation or this helmet. I don't have one here, obviously. They're like $250,000. Do a spin, and then I navigate these pedicle screws down into the bone here, and then put a rod through this part. Then I break off. I don't want to do it on this model, but I break off these towers, and that's what gives you, like, under all the skin here, these things down here. So when people say they can feel their hardware, if you're like an 80-year-old really thin lady, you have no tissue, fine, maybe you can feel. But most people, you have all this tissue above it, you can't feel those screws. So with all that being said, you get those screws. I usually want my patients up and walking that day of the surgery. It's a big part of the care. That's why I use the small incisions. That's why I go through the belly also. Believe it or not, smaller incisions everywhere. So you're up and walking around that day. And in terms of discharge, definitely keep you overnight. And then maybe the next day, but usually it's post-op day 2, post-op day 3. I kind of say I care, but I don't care. If you want to go home day 2, day 3, day 4, whenever it's a two-way street. Not going to kick you out, not going to hold you hostage. But usually most patients go home day 2, day 3. Up and walk around to get home, ice, things like that. I don't want you to lift more than 15 pounds for the first 6 weeks. And that's after one level. That's after any of my fusions or even any of my decompression surgeries. For 6 weeks, you're wearing a back brace, not lifting anything heavy. After 6 weeks, if it's a decompression surgery, I usually take off all restrictions, believe it or not. And that's the decompression side, but we're talking about the fusion side. So whether it's a 1-level, 2-level, it's actually rare to be a 3-level fusion, believe it or not. Like, once you get over 2, then it gets to be multiple. But 1 and 2-level fusion, so from 6 weeks to 3 months, you can do up to 30 pounds. We start formal physical therapy 2 times a week for 6 weeks. After 3 months, you can go up to 45 pounds. After 6 months, usually I let you go back to full golfing. Maybe I say wait for a driver till 9 months, but it also just depends on patient, comorbidities. But I use golf a lot as just a barometer, just because a lot of people are familiar with that. So I say chipping and putting at 6 weeks, full golf, driver 6 months, 9 months. We'll just see. Anyway, so that's kind of a very typical recovery. From Jeff, your ask is Vertiflex good for spinal stenosis? No, Jeff, Vertiflex is not indicated for spinal stenosis at all. So a Vertiflex procedure, if someone's doing it, that's something that a spine surgeon created and now is used by pain management doctors. I'm not totally against Vertiflex, to be fair. I think Vertiflex has roles, but for spinal stenosis, it is not the best thing to use. But it's not terrible, but it's not the best thing to use. Again, I'm on a recorded line, so some of my thoughts are guarded. But I would not recommend Vertiflex for spinal stenosis. Someone else might do it a ton better than I do, but no way. Maybe you just need a laminectomy. Coflex, same thing. Any of those, Vertiflex, Coflex, there's all the same. Interspinous clamp, name your interspinous clamp. They're not curing spinal stenosis. What you need to do is clean out the spinal stenosis. And if they want to put a clamp there because that pain doctor wants to make some extra money and pretend they're a spine surgeon, go for it. But I wouldn't recommend it. Stem cells for disc protrusion, sure, not against it. I just recommend patients. Same thing with disc seal. Those are all things that are cash payment, $5,000, $10,000. If you got the money to do it, if you trust your doctor who's recommending it, especially if it's like a spine surgeon, then I think those are good things to try. I don't offer those myself. So sorry, I'm not the bad guy taking $5,000 to $10,000 for something that's not totally proven in peer-reviewed studies. But I'm not against it if one of my colleagues even started doing it. We're in Texas, Dallas, Texas. From Jeff, I had a lumbar laminectomy fail, now wants to do a Coflex. Jeff, I just can't really give you formal advice here, but that's now a totally different story. So you had a laminectomy, now you're doing a Coflex. It doesn't really make sense. Some of it doesn't add up. I just don't know your whole story, but I can't obviously give you a diagnosis on here. But it sounds like they care about you and they're trying to take good care of you. So we need some other questions here. Had a fusion. Oh, what does that say? Long stuff. T4 to L1 20 years ago. Now stenosis is starting. What can I do? From Jojo. Jojo, I'd love to see maybe, so you have stenosis at L1, L2, I'm guessing. It might just be extending that down 1 year. But, that's one of those things where someone's like, oh, my gosh. And I'm guessing, look, from T4 to L1, you either had a deformity correction in your back and you made it 20 years. So people are saying, oh, once you got one, you need another. Well, look, you made it 20 years, so I don't know about that. That's like saying you get a knee scope and a knee scope and then you need a knee replacement. Shouldn't have gotten all those knee scopes. Well, that's not exactly what it means. My T-lift cost me $90,000. Did you have to pay $90,000 for a T-lift? Because that's really stupid. Not you, but just that's not how. Like if you have insurance, then it's probably whatever your deductible is, $2,000, $5,000, hopefully not $10,000, but that's what some deductibles are. Just because you're inpatient stay, the cages themselves are a couple thousand, the screws are probably a couple thousand, the bio is a couple thousand, and so in the hospital stay, the surgeon's fee is nominal. It's not that. Goodness gracious, they're probably getting $1,000, $2,000. So the $90,000 thing, maybe that's what it was charged to insurance, but I don't think that's necessarily what your hospital was, or the hospital fee was, like what they got. But that's definitely not, that's a lot of money. I'll just kind of leave it at that. All right, let me check one thing here. So, going for microsketching on Tuesday. Congrats. I think you'll do great. Just had an ALIF in December. Claudication better, but back pain is worse. Oh, sorry to hear that. Hard to say kind of what the issue is there. Maybe, you're 3 months out. I'll just kind of give it some time. My ALIF surgery cost $65,000. I'm paying $8,000 after insurance. I just don't know. I can't give financial recommendations on people's insurances, but usually, again, this is well outside my wheelhouse to talk about it, but usually, patients ask me all the time, and kind of what I've heard from my scheduler is, if it's an outpatient surgery, it's not as much because there's not an inpatient hospital stay, but it's those inpatient hospital stays, it's the screws and the metal. But at least everywhere I go, for the most part, I think is in network, and insurance covers all that stuff. So I just don't know why other people have to pay $8,000 afterwards. Hard to say. Maybe, I don't know. You just have to ask your doctor on that one. Do you take people that don't have insurance? I'm kind of going back to that same thing. I will, but I don't like to, only because, again, they want to quote for surgery. And just as people said, you get these crazy quotes, and 98% of that are going to these big Fortune 500 companies, like these big hospital corporations. So I just think, if you can wait it out, try to get insurance and then see me, just so you can use the money you saved up. But I really don't want this to be about money or insurance. Let's kind of talk more about some spine issues. So a couple more things, and then I do have to go. Thoughts on epidural steroid injections from Kimberly? 2 thumbs up. I think those are very helpful. From Patty, where am I located? Dallas, Texas. What's a lateral fusion? A lateral fusion is going from the side here and putting in a cage. From Ashley, what could sustained clonus and Mile Hoffman in the right indicate? It could indicate spinal cord compression. What's the best treatment for spondylolisthesis? The best treatment is watching a video I have on YouTube for it called The Best Video on Spondylolisthesis. And I'm just going to leave it at that. I have a video. It's about 30 minutes. I made it all myself. All my social media, I do myself. I don't outsource any of it. I don't hire a company. I don't send it off international for someone to do it. So I think that gives me a little more authenticity than my peers who are just doing it to make money. Maybe I'm just doing it to educate people, and I do it all myself. What about a blizzard? I don't know what that means. Paresthesias, do I need surgery? Maybe. You got to figure out what's causing this paresthesias. It might not be your spine. How long does it take for the disc hole to scar to prevent reherniation? Maybe 6 weeks. Your highest windows in those first 6 weeks. Leonardo Torres, how are you, Leonardo? Thanks for saying your own name there. Is instability consistent with static 1 degree spondy? From Timothy Cook. It's kind of a long story. Technically, instability is like when you move from one thing to another, it moves on X-ray, or from MRI to X-ray. So if it's a static inherently means it's stable. So it's spondy, but it's a stable spondy. So if you say static, it means stable. If you say non-static, which we never use that term, it's unstable. SI joint pain. Yep, SI joint pain's a thing. I'm not sure what the question is, though. 3 weeks since my decompression fusion. My legs feel great. I'm up walking 2 times a day. From John Welsh. John, thanks for that comment. Good to talk to you. What's your favorite surgery case to do? From Emma. My favorite surgery case to do is an anterior lumbar interbody fusion at either 4.5 or 5.1. I actually don't like carry the way on the level, but usually it's 5.1 with posterior spinal instrumentation, screws on the back. Well, why is it your favorite? Well, honestly, because it's pretty straightforward and easy. The vascular surgeon I use, she's the highest volume in the whole nation, and we're just like fast, efficient, and it's just like a big, powerful surgery with really good outcomes when patients really need it. And it's not like everyone I see needs it at all. You have to have instability, you have to have recurrent stenosis, you have to have disc collapse. In fact, a lot of the fusions I do don't even need the screws in the back. We just do the cage and the plate in the front. So that's my favorite one, just because, if we are supposed to roll back into the room at 7, maybe she makes the first cut at like 7:15. She's done with her part, and we're onto the stretcher by 8, flipped over to the back and do the spin, put on my augmented reality. It's just somewhat stress-free, and it's just a super low complication rate, honestly. So that's why it's one of my favorite surgeries, because you just get a lot done in an efficient time, and it's just not terribly hard in most cases. Sorry, I got a little Martin Garrix singing my favorite song here in the background. Hard to focus. If everyone has their favorite Martin Garrix song, comment in there, and I'll tell you if that's it. I'll see if we can get it. All right, what's a kyphoplasty? That's a surgery that I'll do. I'm not like trying to be the kyphoplasty king of Dallas. I would love it if I could only do one kyphoplasty on a patient and then never another, but usually if you get one spine fracture, you're at risk of getting another spine fracture, right? It's because you have osteoporosis. But a kyphoplasty is essentially, if you get a collapse of this disc of this vertebral body, you can put in this type of needle or probe, put a balloon in to open it up, and then backfill it with bone. And that's a good way to fix fractures. At mine in Dallas, yep, I'm born and raised in Dallas. In fact, I was born at downtown Baylor. So I kind of jokingly say I didn't just move here to take advantage of the nice favorable things for Texas for surgeons. I'm home raised, homegrown. I did leave for 10 years to go do training, med school, residency, research, fellowship, not in that order, research, med school, residency, fellowship. Goodness, I almost forgot what you do after med school, right? Where did I go? I went to Texas Tech. So look, I even got a little. So I usually tell people, where do you go to med school? Harvard. Okay, well, I went to the Harvard of Texas, Texas Tech. So again, staying very Texas proud. And then for residency, I went to University of Miami, all about the U. Everyone knows that. And then for fellowship, I went to the place where they write the textbook. It's called the Rothman Textbook of Spine Surgery. So I went to the Rothman Institute in Philadelphia. And if anyone needs spine surgery in Philly, you got some of the best spine surgeons ever trained right there in your backyard. So I always kind of think it's funny when someone from Philly reaches out and they saw some Joe Blow there. I'm like, oh my God, how did you not go see XYZ? Like, how did you not go see Chris Kepler? How did you not go see Alex Vaquero? How did you not go see Alan Hildebrand? How did you not go see Mark Curd? How did you not go see Barrett Woods? How did you not go see Jose Canseco? I mean, you have some of the best spine surgeons in the entire world right there in Philadelphia. And sometimes they see, I could miss the name there. Up. I might have to go. All right, just like that, my 3-year-old is up. That is my alert to leave. I'm going to end really quickly. That's how these go. Talk to y'all later.